Dr. Rajaman Jacob is the chair of the Department of Radiation Oncology at the University of Mississippi Medical Center. He has over 30 years of experience in cancer-related care. He earned his medical degree from the Medical College, and you'll have to excuse me if I mispronounce this, Trivandrum, India, and pursued an advanced fellowship training at the Royal Marsden Hospital and the Royal College of Radiologists in the United Kingdom. He later completed a specialized fellowship in intensity modulated radiation therapy under the mentorship of Dr. Alan Pollack, one of the nation's most respected radiation oncologists at Fox Chase Cancer Center in Philadelphia. So after relocating to the United States, Dr. Jacob accepted a position as a visiting assistant professor at the University of California, Davis, where he really sharpened his clinical and research focus on gastroenterology. He then joined the University of Alabama at Birmingham, where he spent 18 years building a distinguished academic and clinical career in radiation oncology before being appointed the chair at UMMC in 2024. So we're all very excited to have him come and talk to us about radiation and rectal and anal cancer because he has a wealth of knowledge that he will help us to kind of pick apart the different pieces of using radiation in our practice. So thank you so much.
Good evening, everybody. Thank you, Jordan, for your kind words. I'm very excited to be here with you this evening. It's a Sunday evening, and the fact that you're all here testifies to your commitment to your profession. So it's great to meet with you, and virtually though, and do this little small presentation. So what I intend to do is go over some of the um, facts about radiation oncology, how we do our practice, and then I did not know how detailed I should go into radiation oncology because beyond a certain level, it can get a little boring and can get a little academic. So I thought I'll save that for the end. So if you have specific questions about how we do things, I'll be very happy to talk to you. And I also did not want to bore you with a lot of clinical trial stuff. I thought I should just touch on what I think is relevant to our current practice. And these are clinical trials that we always discuss with our colorectal surgeons. And I thought your radiation oncologists probably have discussed these with you as well. So maybe we can look into it from a rad-onc perspective and see how we should approach treating colorectal cancers in a multidisciplinary setting. So with that introduction, let's move on with our first slide. They say nothing happens by chance, but actually the discovery of X-ray was pure chance. Wilhelm Röntgen in 1895 accidentally discovered X-rays. He was actually conducting some other business in his lab with cathode X-ray tube, cathode ray tube. You can't call it X-ray tube, you can cathode ray tube. And he noticed the luminescence on the walls of the cathode ray tube. And later on, he discovered some of the photographic plates, which were films which were left in the lab, had gone bad because of these rays. And he realized these rays have some weird properties, and he called them X-rays. Just think of it, before the discovery of X-rays, even radioactivity was not discovered. People did not know about radioactivity, which has existed in the universe since the Big Bang. And it was only in 1896, a year after X-ray was discovered, that Henry Becquerel first discovered natural radioactivity. So that is how impactful Röntgen's discovery of X-rays is. And soon afterwards, it was discovered that this magical X-rays had a lot of unique properties. One was penetrability, and so it was put to quick use in both industrial setting as well as in medicine. On the bottom, you see the first X-ray image that Röntgen made of his wife's hand. So this was apparently the first X-ray image. So while more research was happening into natural radioactivity, especially by pioneers like Marie and Pierre Curie, and their children, Eve and Irene, and Marie Curie's and Pierre's son-in-law, Frederick. Um, between the five of them, they have five Nobel prizes within the family. So that's how active the field of radioactivity was at that time. Simultaneously, this gentleman on the right, his name is Victor Depigny in France, he made use of X-rays to first treat patients with cancer. Um, the first patient who was treated had gastric cancer. The patient was palliated effectively, apparently, and survived for a few more weeks without pain. So that's the story. I tried to pull the original paper, but it's not available. But mention of Victor Depigny, I could find in a number of scientific articles. So one has to believe it is true. So let's move on to the next slide. Um, Today, radiation oncology is a specialty on its own. For the longest period of time, it was a subsidiary specialty under the umbrella of radiology. In the US, radiation oncology became a separate specialty in 1922. Um, in a lot of other countries, I know in India, where I did my medical school, radiation oncology was a branch of radiology till the 70s, till the mid 70s. And I think the story is not different in a lot of other countries in the world. So the whole branch of radiation oncology, it has a it is a very new branch, just over 100 years old. And today there is a 4-year residency program in radiation oncology, and it typically begins as in the PGY 2 year. There are around 94 accredited programs in the United States, about 180 positions. Just compare that with surgical training. There are 258 accredited programs and over 1,200 positions for surgical training. So radiation oncology is a very small specialty. It is a very new specialty. And despite that, it is a very important specialty by virtue of the properties of X-rays that we try to make use of. Uh, so this is a split up of our radiation oncology residency positions. Uh, Increasingly, there are a number of international medical graduates who are applying and matching into our residency programs, because the radiation oncology is also becoming very popular all around the world. Radiation oncology was not very popular in other countries up until the turn of this century. That's when a lot of new changes happen, and now radiation oncology is a very cool specialty everywhere, and a lot of people have interest in pursuing this path. So let's move on. Why do medical students choose radiation oncology? When we surveyed our residency applications, the commonest reason was that this specialty offered a blend of technology and medicine. Of course, it is very cool to work with advanced imaging and software and new technology. A lot of applicants, however, valued the long-term relations that they can maintain with their patients. And this is a you're dealing with cancer patients. This is a specialty where you can certainly deliver compassionate care, very similar to your profession, your specialty. And then we tend to maintain long-term relationship, often over many years. And of course, a significant number of applicants were also interested to collaborate with the surgeons, medical oncologists and radiologists, pathologists, and that's very unique to our specialty. And also the opportunity to work with different disease sites. I mean, as a radiation oncologist, you have the option of specializing into one disease site, similar to what I have done, for example. But I also, during my training, I was trained to treat lung cancers and brain tumors and all the other different body sites. So these are some of the reasons why radiation oncologists choose their specialty. Jordan, you may want to advance the slide when I mean, if that's okay. Yeah. So what do we do? A lot of people don't know what radiation oncologists do. We see patients in clinic. We consult our cancer patients. We offer expert opinion, not only in clinic but also in multidisciplinary tumor boards and stuff. We plan radiation treatment after discussing with our fellow surgeons and medical oncologists if that's the appropriate next step. We take care of patients while they're on treatment. We follow up the patients for tumor response. We look for toxicities, all within a very stringent evidence base. So we follow the NCCN practice guidelines. We have very robust journal clubs, and we always try to keep abreast of our literature. And it is almost, especially because we are dealing with X-rays, we are very careful not to um, go beyond the boundaries of what is allowed. So there is a lot of peer review and there's a lot of evidence-based practice which is going on in radiation oncology. Uh, so um, without boring you too much, let me touch upon the basic concepts of radiation. So if you look at the picture on the left, there are two sigmoid curves. The first one, which says tumor, suggests that as you increase the radiation dose, the cure rates go up and you can reach close to 100%, provided you treat with very high doses. Essentially, it is as um, meaningless as saying if you say you can cure all cancers if you increase the radiation dose sufficiently, it is like saying, yeah, you can cure all cancers if you do a big enough surgery. Because there are limitations to doing this kind of treatment due to the sigmoid curve on the right side, where you can see that the normal tissue toxicities also follow a sigmoid curve. And as you ramp up the radiation dose, you are also increasing the toxicity rates. Now, in real life, the sigmoid curves are not widely separated as shown here, or they are not exactly parallel to each other. And you seldom can find a dose that fits in with 95% cure and 5% complication. On the contrary, the dose response curves are mostly squiggly. I mean, they are not perfectly sigmoid. And if you look at the first curve on the, no, if you look at the second picture, the first curve in blue and the first curve in red, they represent the normal tissue response to radiation and the tumor response to radiation. So I'm talking about, I don't know, you can't see my mouse, unfortunately. I'm talking about the two curves on the right side of the second image. So if you look at that image, you can see that with a preferred radiation dose, you can get about 10 to 15 or maybe 20% toxicity and about an 80% cure rate. But if you add an additional modality like chemotherapy, these curves shift to the left, as represented by the dotted red line and the second dotted line on the right side. So the brackets that I have shown there tells you the incremental improvement in cure rates and the incremental improvement in toxicity rates that you can achieve when you add chemotherapy to the mix. So this is how radiation oncologists figure out how to combine different modalities of treatment so that you can improve the outcomes while decreasing toxicities. Let's go to the next slide, please. So it was known that it is beneficial to break the radiation dose into small fractions. As you all know, we don't finish our treatment over a day. We bring our patients for treatment over several weeks. And the reason why radiation was fractionated was to allow the normal tissue to recover in between fractions. So when you cause lethal damage to the cancer cells, you typically cause sublethal damage to the normal tissue, and the normal tissue has the ability to repair itself, and hence the normal tissue toxicity can be repaired before the next fraction is delivered. And typically the time taken for repair of sublethal damage is around 3 to 4 hours. So theoretically, you can space radiation treatment every 6 hours safely. And we do that sometimes. Sometimes we offer twice a day treatment for our patients. But for practical reasons, we do radiation treatment once a day. So that's how we fractionate our treatments. So once radiation was fractionated, it was very soon noted that the total dose of radiation, the dose per fraction, and treatment duration are three very important things which determine outcome. So total dose, dose per fraction, and treatment duration. And if you vary the dose per fraction, for example, it was found that if you look at the picture on the right side, it was found that um, some tissues like bone marrow, which is depicted at the bottom, there is not much impact with the dose per fraction, whether you give it a lot of small fractions or you treat it over a big fraction, the amount of toxicity is almost the same. Whereas some other tissues, such as the skin, for example, or spinal cord, there is a big impact whether you do small dose per fraction or higher dose per fraction. So tissues like bone marrow are early reacting tissues. You develop toxicity very early and at low doses, whereas skin, especially things like fibrosis and other late effects, are very much impacted not only by the total dose but also by the dose per fraction that we deliver. Why is it important? Let's look at the next slide. It is important because, and this is the last slide, and so I will not be showing any more of these squiggly lines. Uh, this is because all tissues have a early response and a late response. It is just that some tissues like bone marrow has a lot of early response and very little late response, whereas tissue like spinal cord has a lot of late response and very little early response. So every tissue inherently has an early reaction component and a late reaction component. And if you want to specify a tissue, each tissue will have a unique ratio of early and late response, and these are depicted using the alpha and beta. So every tissue has a specific alpha beta ratio. Why is this important? This is important, and this occupies a lot of time of radiation oncology practice, because anytime you're changing dose per fraction, for example, you're converting your 45 gray in 25 fractions to 5 fraction treatment, you have to do alpha beta calculations to make sure that you're not causing undue toxicity to any of the tissue that the x-rays pass through. So, you have a patient with a lymph node that you want to do stereotactic body radiation, then you have to work your alpha betas to make sure that you're not exceeding the radiation dose tolerance to any of the structures. So this is a very important thing that radiation oncologists do, often by ourselves, and occasionally taking help of our PhD physicists. Next slide, please. So how exactly do we work? Now, I mentioned earlier that we consult patients, we have tumor board discussions and all that. Once we agree to do radiation treatment, we obtain consent, and patients undergo a procedure called CT simulation. This is essentially positioning the patient in the treatment position with sufficient immobilization, because we don't want the patient to be moving during radiation delivery. And we take a CT scan in the exact immobilization position, and we transfer these images using DICOM software into our planning computers, which is seen in the next picture. Here, the physician contours the targets. The physician will contour not only the tumor, but also the at-risk lymphatics, the normal structures, and then the dosimetrists who are trained to do these calculations will come up with a radiation plan, with multiple beams oriented in different angles, sometimes in different planes, to hit the target in such a way that the target is covered with high radiation dose and the normal tissues are spared. Now, the next step is for the physician to come and verify the plan. And if everything looks good, um, the physician usually looks at the alpha beta calculations and make sure that the dose constraints to all the normal tissue are met and the target is fully covered. He or she will ask for a peer review. It's either one physician or a group of physicians who would review the plan and make sure it is safe. And the PhD physicist now takes over the plan, and he or she would do something called a pre-treatment QA, which is essentially recreating the treatment on a dummy, either a phantom or a electronic device, as shown in the picture, where the radiation is delivered and the doses are calculated, and make sure that exactly this dose which was predicted on the planning system is indeed delivered by the machine. And then the plan would proceed to actual treatment delivery. So these are the steps that we do in our radiation planning and delivery. Next slide, please. Now, I talked about the target delineation. So these are terms which probably you are familiar with. The gross tumor volume, or GTV, is the first that we cover. The GTV is usually what we see on our scans, or that you could physically feel or see on the patient. Around the GTV, we construct a volume called CTV, or clinical target volume. So this accounts for any possible microscopic spread. And for different disease, we have different CTVs. For example, if you have a lymph node that you want to treat, we typically put a 0.5 centimeter margin around it. If you have a bigger gross tumor, we usually put a 1 centimeter margin around it. If there is a anatomical, what do you call a boundary, like a tissue, what do you call a compartmental separation, then you don't need a big margin. Um, if you have, if there is likelihood for submucosal spread, as in bowel, then you have to put a 5 centimeter margin or a 3 centimeter margin. So it really depends on the pathology, the patterns of failure, and kinetics, and different tumors have different CTV margins. Once the CTV and GTV are constructed, you have to also add an extra margin for setup errors, because the treatment is delivered over 30 or 35 days. So every day the patient may be set up with slight difference. And the target may move each day due to organ filling, movement of the bowel, respiration, etc., or even organ deformation, as in the liver. So for that, you add an extra margin that is, and construct a volume called the planning target volume. Now, the setup errors can vary between sub-millimeter for some of the brain tumors to about 5 millimeter for the skull. And in the abdomen, we typically put 1 centimeter. In pelvis, we put 1 centimeter, unless it is for prostate, where we put 3 to 4 millimeters. So the PTV margin can vary. Now, the PTV margin is the actual volume that the dosimetrists start working on. That's the area that we want to treat. But in order to cover that area, you have, by the time you put the beams and you have a plan, you would end up treating a bigger volume, and that is the treatment volume, which is given by the acronym TV. Now, if you have a very modern IMRT delivering linear accelerator, if you can look at the picture on the bottom, um, the one which shows the multiple leaves, that's what the collimator system of the linear accelerator looks like. If you have the ability to shape your radiation beam, then you can have a very conformal um, target volume, and so you will not be treating a whole lot of normal tissue. Some machines, like the proton machine, the particle therapy like carbon, they have unique properties wherein the treatment can be extremely conformal, whereby you can limit the amount of normal tissue that you treat. On the right hand, there you can see a therapist with a patient. That is a contraption that we use. It's called the automatic breath control, which limits the tidal volume, and that's one way we can limit respiratory motion. There are multiple ways. This is one of the ways that we use in our department. Let's go to the next. So when the radiation oncologist does a prescription, we talk about the total dose, the number of fractions, we talk about the total duration, and then we talk about how it is delivered. Typically, it is once daily. We don't treat over the weekend. So some people ask, why are you not treating over the weekend? Because the cancer doesn't stop growing on the weekend. The reason is it's convenient. And there are actually clinical trials which have attempted treating patients 6 days a week, and they have found that the impact of 6-day treatment in head and neck cancer, in some head and neck cancers, is the same as adding systemic chemotherapy. So it's not a stupid question. I have patients ask me that question. And then the radiation oncologist has to very clearly specify which volumes are treated and whether we are going to administer any concurrent chemotherapy or any immunotherapy or any other treatment or any other concurrent therapy along with the radiation. Standard doses, 45 gray in 25 fractions is what we use to treat pelvic lymphatics. That's for microscopic disease. For gross disease, you typically need to do 50 to 54 gray, provided they are going to be removed at surgery. If surgery is not planned, then you need at least 60 gray or even more. If you are going to give intensive chemotherapy like mitomycin rather than just 5-FU alone, then for anal cancers, you typically don't go to 60 gray. You try to reduce the doses. Small tumors, for example, patients with lateral pelvic lymph nodes or oligometastasis, you can completely ablate them using very, very high dose of radiation, like 40 gray over as few as 5 fraction treatment. So these are all standard radiation doses that we use in the GI setting for different conditions. Next slide, please. Now, how do we design our radiation fields? The volumes used for radiation is not only for the primary target, but also for the at-risk lymphatics. And the lymphatics, we know our vascular anatomy. Radiation oncologists are very definitely not as adept as you are, but we try to learn our vascular anatomy so that we can include the at-risk lymphatics. For colorectal cancers, anal cancers, we always cover the mesorectal lymph nodes, the pre-sacral, obturator, and internal iliacs. If there is involvement of uterus or prostate, then we definitely include the external iliacs also. Tumors encroaching the anal canal, and especially if they are below the pectinate height, then we also add the groin lymph nodes in our treatment volume. Now, this practice is currently being thought to be a little excessive in some special situations, and we'll talk about that later. Let's move on. This is what the radiation fields look like. Most of the time, we use very simple radiation field setup with a beam coming from the front, one coming from the back, and one coming from each side. And we block off areas which we think are not needed to be treated, because we want to spare the small bowel, we want to spare the femoral heads, the bladder, the external genitals. All those areas are shielded using lead, and we treat the at-risk area. Now, in some situations, you do 3-dimensional radiation planning using intensity modulation. And this is typically in case of post-operative radiation, because there's a lot of small bowel in the pelvis and you don't want to radiate all the small bowel. So we try to shape the beams and use more modern techniques so that we can avoid toxicity. The same with the re-radiation for recurrences, or in any situation where you think you are over-treating the bowel, you can use complex plannings using intensity modulation. Next slide, please. Um, there are two courses of radiation that we typically use. One is the long course, that is 45 gray in 25 fractions. I'm sure you're all familiar with that. And this is delivered with concurrent 5-FU or capecitabine. Surgery is typically performed at 4 to 8 weeks. And short course radiation is also popular in some setting. We deliver a dose of 25 gray in 5 fractions. In this situation, we do not deliver any concurrent chemotherapy because you're using very high dose per fraction. And this is, you can increase the toxicity if you add chemotherapy to this mix. For patients who don't need any cytoreduction, surgery can be done pretty quickly. But if the cytoreduction is needed, then surgery is delayed until 8 to 10 weeks. Typically, if you're doing treatment for bulky disease, T4, at-risk CRM, as in the Rapido trial, for example, then the surgery is delayed. But if you are doing it for all other tumors where there is no risk and the tumor is small, there is no need for the surgery. You can easily do a LAR, then there is no need to wait for 8 to 10 weeks. You can straight away go to surgery within a week. Now, there is also a technique with the modern linear accelerators. You can treat one area to, let's say, 45 gray, and you can take the other area to 60 gray simultaneously. And because these modern linear accelerators are capable of delivering different doses to different areas. This technique is called simultaneous integrated boost technique. We often use this technique when we have lateral pelvic lymph nodes, for example, or if you want to increase the radiation dose just to the tumor, but not to the lymphatics, then you can do 25 gray to the lymphatics, which is our standard short course radiation dose, but you can give 30 gray in 5 fractions simultaneously to the gross tumor. And if you have lateral pelvic lymph nodes, which the surgeons typically don't operate, you can do 40 gray in 5 fractions. So in our practice, when we, in our multidisciplinary meeting, if we see lateral pelvic lymph nodes, we discuss with our surgeons and we ask them, are you planning to operate on these pelvic lymph nodes? My surgeons usually in the beginning, they would always say, yeah, we are going to remove the lymph node, but why don't you do 40 gray in case we can't remove them? That was the answer in the beginning, but later on, because of excellent response, our surgeons don't even attempt to remove them. They are happy with us proceeding to 40 gray in 5 fractions to these lateral pelvic lymph nodes straight away. So that is how we do the different radiation courses in different scenarios. Let's go to the next slide. Now, do all patients need radiation? Do all patients need chemotherapy? Obviously, the answer is no. And this is a slide which gives us a reasonably good idea of what constitutes risk for distant metastasis and what constitutes risk for local pelvic failures. Now, right in the middle, we have a group of tumors, T1 to T3B, no additional risk factors, where you probably don't need any additional treatment. Surgery alone may be enough. So these kind of information which we have accrued over a large number of clinical trials is what helps us to take day-to-day decisions in clinic. Let's move on to our next slide. So one question which was asked in one of the recent clinical, we'll go to some of the important clinical trials now. One question which was asked in one of the recent clinical trial is whether for the tumors occupying the middle zone, there is any need for radiation. So we are all familiar with the prospect trial. It randomized patients to the standard arm with chemoradiation followed by surgery and adjuvant chemo, and the experimental arm, which was chemotherapy. And if there is a good response, don't give them radiation, proceed to surgery. If there is poor response, of course, you add radiation. And then the results of the study showed that there is no difference in overall survival or disease-free survival or local recurrence with the avoidance of radiation. So this shows proves the paradigm that there are groups of patients which especially which occupies the mid zone in our picture in our the figure that I showed earlier, where there is no need for additional radiation treatment. And Astro and ESMO, they have both come up with consensus guidelines. And by and large, it is agreed that for tumors T1 to 3B, upper tumors, no lymph nodes or minimal lymph node involvement, good margins, there is no need for any radiation. Let's move on. But if you look at the historical perspective, I know it is exciting to avoid radiation, and I'm as a radiation oncologist, even though I was not a big fan of Prospect when the study was being done, I thought it is a very interesting question. And when the results came out, I was actually very happy that there is no need to do radiation unnecessarily for a subgroup of patients. So that's very good, and we refer patients for uh, um, chemotherapy only followed by surgery when there is no risk factors for local recurrence. If we look at the historical perspective, we have moved from big surgeries. Then in the 90s and 2000s, we defined the role of radiation. We have a bunch of systemic therapies which came up in 2010s, and more recently, we are talking about all the genomic profiling and other things which we are integrating into our clinical practice. But all of this is pointing towards organ preservation strategies. So the prospect study is only part of the answer. It is good that we don't need unnecessary radiation, but the question is that what we can do to move towards organ preservation? So that's a big question. Next slide, please. And why is it important? Because if you look at the evolution of surgery in all different body sites, people have moved away from big surgeries. People have moved away from amputations and APR and big mastectomies and all that. The idea is to preserve organ, and idea is to improve quality of life. In bladder cancer, for example, there are lots of clinical trials looking into chemoradiation for bladder preservation. And similarly, in rectal cancer, we are talking very actively and looking into ways and means wherein we can preserve the sphincter and thereby improve quality of life. So in that perspective, I think Prospect is only helping us halfway with additional information, but that's not the end game as far as colorectal cancer management is concerned. Next slide, please. So for tumors in the middle zone, the one which was depicted in green, this is a study with the TREC study, which looked at using radiation alone in very early stage tumors. This study randomized between short course radiation followed by transanal endoscopic surgery or standard treatment of total mesorectal excision. With this study, it was possible to preserve the organ in around 70% of patients without any significant difference in overall survival, DFS, or relapse-free survival. And naturally, patients who had organ preservation also had good quality of life and lower adverse events. Now, this study was prelude to the next study. Please go to the next slide. The Star Trek trial, which was recently presented at the ASTRO 2025. This study randomized patients between short course and conventional chemoradiation. And then patients who had complete response was kept on observation, went on to the watch and wait policy, whereas those with a partial response underwent transanal endoscopic microsurgery, and those with poor response had TME. Now, we only have very early results from this study, but it was found that 80% of the patients who were treated with long course chemoradiation and 60 with the short course chemoradiation could avoid a big resection. And the treatments, both the treatments were well tolerated, very little toxicities. But obviously, we need to see long-term results to confirm that the early findings, the results still hold. Now, one interesting thing about this study, remember, this is the subgroup of patients where the radiation was omitted in the prospect study. So in this study, the radiation was given slightly differently. The concept of mesorectal chemoradiation was introduced here, where the patients received just radiation with the primary target only, no pelvic lymphatic radiation. So in a way, the short course radiation or the long course radiation to the primary target and surrounding mesorectum was doing essentially what surgery did in the prospect trial. So if that can um, shrink tumors sufficiently to do a transanal endoscopic microsurgery and help with sphincter preservation, that would be a very important finding. Let's move on to the next slide, please. Now, we are all familiar with OPERA trial. This looked at patients who are on the on the outside of the realm of those early stage small tumors. These are larger tumors, T3, T4 tumors, or many with N1, N2 disease. Patients underwent chemoradiation followed by chemotherapy or chemotherapy followed by chemoradiation. They had their tumor response evaluation, and those with incomplete responses were taken up for TME, and those with complete underwent watch and wait. Once again, we are all familiar with this study, so I'm not going into great details. DFS was 76 in both arms. There was a 3-year TME-free survival of 41 and 53% respectively. Let's go to the next slide. Most importantly, organ preservation was achievable in roughly half of the patients without any detrimental outcomes. Most of the recurrences, as we know, in patients who undergo watch and wait occur within the first 2 years, and failures are pretty rare after 2 years. And the trials were recently updated. Still shows that organ preservation is a very feasible strategy with neoadjuvant chemoradiation and chemotherapy. Next slide, please. Now, at the UAB colorectal clinic, we have a watch and wait protocol for patients with rectal cancer. This is what we have been doing. We don't have a protocol, but then we have a database where patients with excellent responses are taken up for watch and wait. Next slide, please. Now, for tumors which are in the lower end of the rectum, it is even more difficult to do sphincter preservation. And this is an interesting study which was published a couple of years and recently, sorry, it's probably more than a couple of years. It was probably the update came up this year. So this is a study which made use of brachytherapy boost using contact X-ray. So this is essentially superficial X-rays delivered very close to the tumor using a special applicator. So the way the study was done, there were 2 arms. One was the long course chemoradiation with capecitabine followed by external radiation boost. And the other was long course followed by contact X-ray boost. So the strategy here is increasing the radiation dose to increase response rates. Let's go to the next slide. This study showed that the 5-year organ preservation rate, bear in mind these are early tumors, was significantly in favor of contact X-ray brachytherapy. As many as 80% of patients could avoid APR with the use of contact X-rays. And if the tumor is small, less than 3 centimeters, the organ preservation was as high as 97%. The main side effect was rectal spotting. This was due to telangiectasia, which developed as a consequence to the extra radiation that is given. But they could be managed in most cases, and typically after 3 years, they disappeared. And there was no alteration in bowel function because of the X-ray brachytherapy boost. Next slide, please. Now, even though sphincter preservation is very attractive, it is not without challenges. There are potential for dysfunction and impaired quality of life by doing additional chemoradiation. And this can result in incomplete defecation sensation and incontinence, poor quality of life. And we know that from, I mean, we are all aware of the LAR syndrome that patients experience, and with the chemoradiation, patient experience the same kind of symptoms. Why does this happen? Radiotherapy can damage sphincter muscles, can result in its ability to hold, and then histological changes in the mucosa can result in increased mucosal sensitivity. Then telangiectasia, I mentioned earlier, can lead to rectal bleeds. And what can we do about this? Clearly, there is need for more research in this realm. Patients should be selected depending on their risk factors for developing these problems. And then after chemoradiation, I think we should get into routine assessment of these patients to evaluate anorectal function and identify patients who are at risk of developing these and intervene early. Obviously, the early cancers you can treat with less radiation, and that might help. And addition of other systemic agents and immunotherapy is something people are talking about, and anal cancers for sure. That will help to mitigate some of these toxicities moving forward. Clearly, there is a lot of research which needs to be done. Um, Retrospective analyses are very of limited value. We don't have a whole lot of prospective evaluation, but there are a few studies. But I think a lot more needs to be done if we are serious about pursuing sphincter preservation and maintaining good quality of life. Next slide, please. Now, in anal cancers, I just mentioned about the addition of immunotherapy. For advanced stage tumors, we already use metastatic tumors, for example, we use immunotherapy. Now, with more advanced stages, there are studies looking into adding immunotherapy or targeted agents, making use of ctDNA, etc., to personalized treatment. And there are also novel radiation techniques which we are evaluating, such as grid radiation, which will help to possibly increase the response rates in advanced cancers. This is a big problem with anal cancers. Patients with early stage disease, it's pretty straightforward. They are curable. But the ones we present, I mean, the ones which come to my clinic, they all have 10 centimeters, 15 centimeter tumors, huge tumors. And they are not the ones which would typically get treated and cured with our standard chemoradiation. So they need additional input or additional help from modern interventions. Now, on the other hand, the strategy for early stage disease, which are already curable, we know, is to reduce toxicity and improve quality of life. One major step was a few years ago, we completely transitioned from our conventional radiation to using intensity modulated radiation, wherein we can target the tumor and at-risk volume much clearly. We could avoid skin toxicity and other GI toxicities in a big way with the use of IMRT. Now, there are a lot of studies looking into reducing the intensity of radiation, dose, reducing the chemotherapy, etc., for early stage disease. There are two such studies. Let's go to the next slide. Two such studies worth mentioning. One is the ECOG 2182 decree study, two arms. The de-intensified arm uses IMRT to a lower dose and use only one mitomycin, one cycle of mitomycin as opposed to two. Results are awaited. And let's look at the other trial. This is the uh, Act 4 trial, very similar concept, reducing the dose of radiation to see if we can achieve the same amount of tumor control with reduced toxicity. The early results which were presented recently show that this is feasible. The results are favorable, but we still need to wait for the local regional control results. So this is the direction we are heading as far as anal cancer is concerned. Next slide. So based on all that we looked at recently, I mean, just now in our talk, it is very clear that an effective treatment for colorectal cancers, anal cancers requires a multidisciplinary approach. We have to incorporate help from our medical oncology colleagues and rad-oncs and surgeons all need to work together. I mean, in most institutions, the surgeons spearhead this collaboration. So, I mean, I call upon you to continue to do that. So we need to see patients together and accurately assess their risk and then collaborate to figure out what is the best treatment for them. Now, there are new treatment techniques, both on the radiation side and systemic therapy that I talked about, which we can utilize. I think the most important thing is to work towards sphincter preservation. That's the next important thing in the management of colorectal cancer. I'm pretty sure within a few years it will become the standard treatment, and we should work towards it, especially in improving the quality of life following sphincter preservation. Next slide, please. I just want to leave with a few comments. This is taken from one of our surveys, what radons say about colorectal surgeons. Everybody loves working with surgeons. I mean, obviously, you guys are great with your surgical abilities. So all very positive. They do the dirty work literally. Without them, a lot of our rectal cancer cases wouldn't even be curable, which is very true. I have great respect for all my colorectal colleagues with whom I have worked in the last 20, 25 years. They're outstanding people, and I have the greatest respect for each and every one of you. There are also some pet peeves. Let's go to the next slide. So this is not about colorectal surgeons, and I will not say this is about colorectal surgeons because you guys are very highly specialized and most of you all work in academic centers, but there are some frustrations that rad-ons feel. I'm just sharing with you all. One is late referral. I mean, we would always appreciate if surgeons talk to us early about a case so that we can be included and we can be prepared. So I think that's the first two things. The third, which I have not seen at UAB or UC Davis, but I definitely encountered this in one of the private practice satellite clinics that I worked. I used to get patients with margin positive, and the patient knows absolutely nothing. They think they are cured, and then I tell them, "Oh, you need radiation, by the way," and they don't like that. And then one last thing is, once again, this is in the satellite clinics. I did not encounter this in UAB at all. Some surgeons are very quick to take patients to APR after chemoradiation. They come for follow-up, and 1 month or 2 months, they say, "Oh, there is tumor left behind. Let me take them to APR." So all these are all once again highlight the fact that we should all work together. We should learn from each other. Please continue to educate the radiation oncologists. They sometimes they act as they know everything. They usually don't know much about what you all do. So I think that's probably the key here. And the last slide, let's go to the next one, please, Jordan. So this is, I'm very excited to move to University of Mississippi Medical Center because we are working towards the state's first NCI designation. I'm sorry about the spelling mistake there. We very, very badly lack a good modern cancer center. So that is something we are actively work on. There is interest in part of the state leadership and the university leadership. And the caption is, "It's about time." It is about time that Mississippi had a big cancer center. And it's also about time because a lot of cancer patients don't have a whole lot of time. So I think it is really appropriate that we work towards this. And I'm soliciting everybody's help towards this. Please talk to your colleagues about this exciting thing that's happening in Mississippi. Thank you very much. And I really appreciate you all. I'm happy to take questions.
That was a fantastic talk. Thank you so much. It's pretty exciting that Mississippi is getting its first real big cancer hospital. Working down in Louisiana at Tulane and taking some away rotations as a medical student, you saw some of the really poor access to medical care that you can really get in that area. So kudos on really starting something really fantastic. I had a couple of questions.
Mhm.
Um, Treating lateral pelvic lymph node treatment, I feel like there's two schools of thought as a colorectal surgeon. One is the lateral pelvic lymph node dissection, which is pretty few and far between for fellows to really get a good look at how to do these. What has been your experience treating these lateral pelvic lymph nodes with localized radiation in terms of the recurrence rates, the local recurrence rates? Because I've been seeing some data that says that with, significantly sized lateral pelvic lymph nodes, you can get, recurrence rates locally as high as like 20% or so, which is pretty high. So just curious your thoughts.
So my experience is that the lateral pelvic lymph nodes, the only guys who routinely do the lateral pelvic lymph nodes in our institution were the urologists.
Mm,
Colorectal surgeons, whenever they attempted to do lateral pelvic lymph nodes, they always call the urologist to seek their help. I mean, I think, or they planned a combined procedure. That's how it was done. Um, Most of the time, the lymph nodes which get referred for radiation are not big ones. These are maybe 1 centimeter, 1.5 centimeters. That's the biggest, typically the sizes that we encounter. Most of the time, they are much smaller than that. And with the appropriate radiation dose, if you give 45 gray in 25 fractions, those lymph nodes will not get controlled. But you do simultaneous integrated boost to roughly 64 gray, or if you're doing 5 fraction treatment, you do 40 gray in 5 fractions, and that is the equivalent of doing very high doses like 90 to 100 gray equivalent. You can do that only with very sophisticated technique. You can do that only if you're sufficiently far away from the bowel, and you can only do that if the tumor is small, the lymph nodes are small. With that kind of radiation, we never see, I mean, I have not seen and I have never heard about local recurrences after that high doses. But it is true, if you don't give or you're unable to do very high doses of radiation, especially the tumor is big, um, one big possibility why high doses could not be given in such situation would be because of proximity to small bowel. So if you can't deliver high doses, then you're very likely to have local recurrences. So I think if you have small tumors, it is definitely advisable to attempt um, high radiation dose if the department has the ability to deliver simultaneous integrated radiation, which most modern radiation oncology centers has the ability. And you have, especially if you have an experienced or dedicated GI radiation oncologist, that is very easy to achieve. If you have a large 5 centimeter lymph node, then you are very unlikely to control it because the likelihood of delivering high radiation doses of impossibility due to the proximity to bowel loops and stuff.
Yes, thank you. That was a great answer for that. kind of dovetails into another question I had about treating these periaortic lymph node metastasis. Sometimes I see the radiation oncologists treat that with localized radiation therapy. What is your kind of proximity to small intestine or large bowel where you think that this is not really a feasible option?
So once again, this is also opening up new possibilities. Now, the big thing which has happened in radiation oncology is the computational power and the imaging technology. They have improved tremendously over the last few years. In the systemic therapy realm, we have a lot more options with regard to biological therapies, immunotherapies. So oligometastasis, for example, increasingly are being considered for definitive curative intent treatment. Um, and there are multiple clinical studies in other various disease sites which have shown that if you have an aggressive approach treating oligometastasis, few, like typically 2 or 3 lesions, you should attempt to do that. Now, if you have widely metastatic disease and you have a scenario where you do chemotherapy or biological therapy or immunotherapy and you have one lymph node or two lymph nodes that are not responding or getting bigger, that is not the exact same situation, but still the treatment that you deliver is still going to be the same. You're going to still do aggressive local treatment. So even though the intent is different, the technique of treatment delivery is going to be the same in both situations. In both situations, if you have the ability to do high dose radiation safely, you should attempt to do that, and you can control the lesion, the lymph nodes, provided you can give those high doses of radiation. You need an equivalent of around 70 gray or 64 gray, 70 gray. Or if you can reach that equivalent radiation dose, then it is worth attempting radiation um, uh, to those sites. Any dose less than that, because of proximity to small bowel loops, then it is going to be of palliative benefit. Now, that brings us to the question, how close is close? For modern imaging and modern treatment delivery, with the modern accuracy of treatment delivery, we can treat tumors which are as close as zero point 0.5 to 1 centimeter from the lymph node, from the small bowel and large bowel.
Mhm.
So I think, especially if you have the ability to visualize the lesion on the day of treatment and adjust your the position accordingly, then you can definitely address most of these lesions.
Understood. I know you mentioned the Opera trial. It's funny how those two trials have such similar names. What kind of specialized equipment would you need for that very close contact boost radiation? And I guess where can you find this equipment if, so your practice setting is like a Kaiser-based setting or potentially more community-based? Are you going to have to refer them to, a large academic center?
So the contact therapy is otherwise the superficial X-ray machine which was used in this treatment. This is not a new treatment. It existed since the 50s, if I remember correctly. It was pioneered by a gentleman by name Papillon in France. I think he's from Lyon. So what the authors have done is basically do a prospective randomized study. Though there has never been a prospective study, a randomized study looking at this technique, even though there are multiple publications from Papillon's group. So this machine is available in a lot of places in Europe. There are few companies which are marketing that in US. It is not a very expensive machine. If there is a colorectal surgeon who is interested in doing this treatment, it is very easy. The machine, they will come and install the machine. free of cost, and you can pay them later once you have your reimbursement. It is actually something which has been ignored and looked away till the opera trial results came out. So this is, I think, a very good treatment, especially for very early stage tumors which are low lying. I think there are multiple centers in England, for example. There are a few centers in Canada which offer this treatment. At our last Astro meeting, which is our national meeting, there were multiple, I think one or two companies which were marketing these machines. They had their booths and they were desperately trying to attract interested parties. Now, one other thing not dissimilar to the contact radiotherapy is actual implanting of needles. There are centers which do radiation seed implant, radiation wire implants. There are centers which do gynecological applicators. So basically, these are intrarectal applicators, not a special machine, but it's the same machine that they use for treating cervical cancer and endometrial cancer. Just they have a modified applicator to suit the rectum. That is a even more practical thing. You don't need to invest in a new machine. You're just making use of what you have in the department. So that is also gaining popularity. In Memorial, they have there's a team who have been doing brachytherapy for rectal cancers as a boost. The other big center, I think, University of Colorado has some experience doing that. Then Montreal, they have a fantastic setup there. So there are lots of places where they do brachytherapy using the intrarectal applicators, not the contact X-ray type treatment.
Understood. We have a question from the thread from Zayad. Thanks for sharing the Star Trek trial. Be interesting to look that up. But what were the inclusion criteria and the stage of these tumors treated?
So the Star Trek trial included patients who have up to T3B, if I remember correctly. So these are patients who very similar to the prospect trial. So it is, they test, essentially what they did was they were testing the possibility of sphincter preservation, avoidance of big surgery in the group of patients where it was shown to be feasible to avoid radiation. It's the same group of patients.
Yeah. Well, fantastic. Thank you so much. Sorry, everybody. I know we ran over a little bit. We should have worked on a little bit of the coordination for the screen sharing, but I think there was probably a glitch in Zoom. So thank you so much for talking with us. It was really enlightening to kind of get a deep dive onto the different trials about localized therapy versus short course and lateral pelvic lymph node disease. And we look forward to, having our users come and review your talk a little bit later too. So thanks.
Thank you very much. I really appreciate the opportunity.
Of course.
Thank you.